So the last speaker is Dr. Pamela Woodard. She's the Vice Chair of Research in Radiology at WashU in St. Louis. She started as an MR radiologist, but she now has become expert in multimodality, including CT and PET. Today, she's going to talk about multimodality plaque imaging using MRI and PET. Pam?
So thank you very much, Debiao, for having me. Also, Paul Finn and Trunyan. I'll be talking a little bit about some of the things that we've been doing, and very recently we just got a grant. We're working with Debiao and his team will be a second site where we'll be sending some of our radio tracers out to try some of the things that we've been doing on a second PET MRI. We have identical systems, so I'm very excited to be once again working with Debiao. He didn't mention this, but years ago we were in the same lab. And I was a fellow, and he was young faculty. So here we are. So Debiao, now you're famous. So I'm still a Mallinckrodt. So anyway, basically we've talked a little bit about how MRA is useful, and then also wall imaging, and we'll be talking a little bit about more of that as well. You're looking at the techniques that have been developed by Trun and then also by Debiao's group, kind of moving things forward to look for plaque characterization. But then there's some additional things that we can do to look for inflammation, and that can be additive from PET. So the modalities where we can look at PET and MRI together have the potential to provide us with some additional information in risk stratifying patients. So this is a standard time of flight routine MRA angiogram in somebody who is asymptomatic. And so we have patients like this who come to us, especially as we recruit them. They're going on to endarterectomy, we are imaging them, and they say to me, can you tell me whether or not my plaque's going to rupture before I go to the OR? Because I don't want to go to the OR. And I feel fine. And so essentially, what they have are by guideline, guideline documents, a stenotic lesion that is, maybe 60, 70%. And because of those guidelines, they're heading off for a carotid endarterectomy. However, some studies have demonstrated that really, even as low as 1.6% of those individuals would actually have a stroke. So it's there are some that say 5%, but really it's quite low, which would make you assume that 98% of those procedures are unnecessary. And CREST-2 is ongoing now. There's the goal of identifying the best methods of treatment for some of these patients. I think Cedars is involved. A number of other, it's going to end in 2026, I think, but they, can you treat some of these asymptomatic patients medically without going on for procedures? And in order to determine that, better methods of risk stratification are necessary. So this is an example of a study done. Jay Zhang was working with me. We had brought this patient in, and it's, essentially same types of stuff that, Tron's been doing, where we're looking at a patient with multi-parametric MR imaging, and you can see that this patient has some old hemorrhage, dark signal in the atherosclerotic plaque on T1, T2, proton density, a little bit of speckling there, and then we have our GRE sequence. And then, Debiao's group has really taken this one step further with the match sequence, where rather than acquiring each of these separately, you can acquire them together, and then on top of it, get a T1 and T2 map where you can provide quantitative information, which could then be used in, for instance, AI algorithms. So it's not just, well, is the signal, bright, dark? But this could all be used, especially what would be needed to move this forward are, as you can see with the Mackay challenge, an algorithm that would not provide only segmentation, but also would provide image classification, where all of this could be fed in, and you could say, well, rather than sitting there going through each one and saying, well, this is bright on this and dark on this, and this must be, just having an image classification program, so it'd be one-stop shop. I guess we hate that term. We've been there before with the coronaries, but really something where, the average clinician could go ahead and our clinical radiologist could use this method. And so WO has, validated this against H&E and pathology. And so in some of our studies, we're planning to incorporate this and then also move on to coupling that with PET imaging. So you can see this patient has this hemorrhagic, plaque. It's old hemorrhage, and might be considered stenotic. However, you can see that with the simultaneous PET, there's really no FDG uptake. And so a lot of people have done FDG imaging. FDG is a glucose analog, so it kind of looks in general for glucose, for inflammation, anything that's metabolically active. You can see in this patient who doesn't have much in the way of atherosclerosis, just a little, there is some uptake. So one of the questions ultimately is, how can you use these radiotracers to predict patient outcomes in terms of event? And, histopathologically, we talk about lipid necrotic core, which you can see on MR, the thin fibrous cap, which you can see on MR. And then, then we have this next step where it's cap infiltrated with macrophages. And at this point, this isn't, you don't see this on MRI. But in addition to just the macrophages, plaque itself is a microcosm of complex activity. There's, the monocyte adhesion molecules, they come in, you have, it scavenges lipids, and then it becomes hypoxic, and there's apoptosis, and then you start to get angiogenesis, and so there's alpha V beta 3 on the angiogenesis. We have NPRC that we're looking at on the vascular smooth muscle cells and on the macrophages. So that kind of gives us some question as to, what's going on there. Can there be PET tracers that will tell us a little bit more about what is going on in the plaque itself on a physiologic basis? So what if we could do, precision imaging? And the PET-MR is an ideal tool for this. These are a couple of our technologists working on our scanner. And so we started looking at, I mentioned very briefly NPRC. It's a natriuretic peptide receptor. And there's a fragment of a natriuretic peptide that binds to this. And the receptor is present on both vascular smooth muscle cells and macrophages. And we found it principally in deep intimal macrophages. So, it's interesting because in the literature, people have talked about NPRC being responsible for vascular smooth muscle cell migration during atherosclerosis. So we took a fragment of the full-length peptide and we started looking at that as a radiotracer. And so one of the things I just want to briefly mention, and this is a figure from Gary Owen's group at University of Virginia, where he has hypothesized that there's a phenotype change, that some of these macrophages, vascular smooth muscle cells, migrate up into the plaque. They keep migrating, and some of them even end up in the endothelium. But that is what happens, one of the components of what happens when a plaque becomes inflamed. So one of the portions of our grant is actually to look at the tissue. We're going to take ex vivo specimens of these patients that we image and do site-seq and RNA sequencing to determine, where do these cells come from? They're in the plaque right now, but did they come from vascular smooth muscle cells, or did they come from the bloodstream where they recruited? So this is some of the histopathology that we did. When we first started out, there wasn't as much as in the literature as we liked, so we partnered with some vascular biologists and actually started publishing some of our own stuff. And you can see in this that the natriuretic peptide receptor is present in maximally diseased versus minimal. And then also, in the deep intima, and let's see if I can, yeah. So you can see it in the deep intima of the atherosclerosis. We then partnered, we had a program of excellence in nanotechnology, And so we partnered with a group at UCSB, and it was kind of interesting because, you might say, well, we put a nanoparticle on this fragment, and then radio-labeled it. And we put it on for two reasons. One, it increased the intravascular half-life of the agent, and helped with allowed more circulation for binding. But then also, secondly, because it was a Program of Excellence in Nanotechnology grant, and if we had no nanotechnology in it, we wouldn't have gotten the grant. So it worked out quite well. We partnered with Craig Hawker at UCSB, and he had provided us with a comb. It's a methylmetroxylate backbone and some polyethylene glycol arms, and we put the peptide on the arms and then radio-labeled this with copper. And so, we started out with a feasibility grant, and that's the one that just ended. Now we're moving into, it's feasible, but does this predict any type of outcomes? And that's what we're working on now with Debbie. So this is an example from one of our patients, and you can see this is in the MR imaging, where you can see the multi-weighted sequence, and then uptake in the atherosclerotic plaque, suggesting that this is a metabolically active plaque, plaque with macrophages, and also, the NPRC is present. This is a pathology from a similar patient, not the exact same one. This is one that we've published, and you can see that in taking this out and looking at the H&E and VVG stains, we then went on to do immunohistochemistry to look at the presence of the NPRC and then also macrophages, and kind of look together to see, do they co-localize? We were able to see that they do, and then also did the autoradiography so we could see the NPRC presence, and then blocked, so we were able to demonstrate some specificity. So besides NPRC, there are a host of other types of things which could be targeted within endothelial cells, vascular smooth muscle cells, macrophages, monocytes. We have another grant with one of our radiochemists, and Rob Groppler, who's another nuclear medicine cardiologist at WashU, to look at a receptor for CCR2. And so essentially looking at macrophages that express CCR2. So there are a number of different things that you can look at, presence of macrophages, hypoxia, that can tell you more about the plaque. And so these are the ones that are in humans. So if somebody said, well, could I do this at home? Certainly not proven, but sodium fluoride is available for prostate cancer PET. And so that's something that could be used in looking at coronary arteries. People have done that and have also started to look at outcomes. The CNF comb, which is ours, copper ATSM, a little bit controversial because people kind of like FMISO instead, but this is an agent that targets hypoxic plaque, specifically looking at hypoxic macrophages. So we had a student who presented that and wrote that up in circ imaging. Other people have looked at things that target alpha V beta 3 in both macrophages and angiogenesis. And then gallium-68 dotatate, which is used for pancreatic cancer imaging, it looks at targets a somatostatin receptor that's also present in a subtype of macrophages. So this is just a quick example of folks here also at Cedars have looked at sodium fluoride, and this is a patient who had an MI and cath, and they went ahead and did, this is coronary CTA, so multimodality with CT and PET, and saw uptake in the vessel. And what's nice about this too is that FDG, which is commonly used, which is a glucose analog, is also taken up in the myocardium. So this specifically is taken up in the vessel in plaque that's laying down new calcium. Copper ATSM, which I mentioned, targets hypoxic cells. We kind of repurposed this. This agent was being used to look at cancer patients to determine whether or not the tumor would respond to radiation or chemotherapy. And we gave this to about, I think it was 8 patients that had were going on to endarterectomy and then got their specimens afterwards. We're able to give them pimonidazole. It's a very safe dye that they can take beforehand. So when we take their plaque out, we can see the uptake in hypoxic cells. So we were able to look at that and then also stain with HIF and then also CD68 And you can see that essentially what is happening is, oops, let's try and go back, is the co-localization, of the hypoxic macrophages. And, the area of hypoxia is co-localizing with CD68, indicating that these are hypoxic macrophages. Gallium-68 dotatate, again, another example of an agent that could be very useful in comparison to FDG. This is, from Dr. Tarkin's group, but comparing to FDG, where you see all the FDG background in the heart, very difficult to look at atherosclerotic plaque because of the background within the heart of FDG. So gallium-68 dotatate can provide an alternative for that. And that's, again, something that's clinically available. You just repurpose it for this indication. So PET and MRA methods that are very complementary. Together, they have the potential to further help us risk stratify. And so together, we have the potential to get more information than we otherwise normally would. And so lastly, this is a group of all the folks who collaborate with us. Yongjin Liu, who's the radiochemist who, helped us put all this together. Mohammed Zayed, who is our physicist, our vascular biologist, our coordinators. And then Monica Shokin. There were just a whole bunch of a couple of our students up there. And, and then last but not least, who we will be working with, Yibin Z and Debbie Au at Cedars. So thank you very much.